is Law and Ethics Group 11, and we're going to be debating the ethics of medical marijuana. Okay, so I'm going to start with the definition of marijuana as defined in the United States Code of Controlled Substance Act, and also the definition of a Schedule I drug, which is what it is classified as in the United States. So, the definition of marijuana as defined in Title 21 of the United States Code of Ethics of the Controlled Substance Act is, the term marijuana means all parts of the plant, cannabis sativa, whether grown or not, the seeds thereof, the resin extracted from any part of such plant, and every compound, manufactured, salt, derivative, mixture, or preparation of such plant, its seeds, or resin. The definition of a Schedule I drug consists of three basic categories. It has to, one, there has to be a lack of accepted safety for use of the drug or other substance under medical supervision. Two, the drug or other substance has no currently accepted medical use and treatment in the United States. And three, the drug or other substance has a high potential for abuse or dependence. I'm now going to argue that marijuana should not be listed as a Schedule I drug because of evidence has shown it does not fit into any of these three categories. I'm going to start with the lack of accepted safety for use of the drug or other substances under medical supervision. The FDA has certain criteria they have to meet when testing drugs' safety and efficacy. It has to have studies showing scientific evidence of its pharmacological effects. It also has to take into consideration current scientific knowledge regarding the drug. It tests for safety first in animals and then in clinical trials in humans. The most obvious concern when dealing with drug safety is the possibility of lethal effects. Can the drug cause death? A lethal dose of marijuana has not yet been recorded in a human in history. This makes the margin of safety extraordinarily wide for marijuana, especially when we consider such drugs as aspirin or ibuprofen, which are over-the-counter drugs. Provided in this manner because they are deemed to be safe, have a low risk, and have many benefits. Yet, according to a publication from the FDA, there are approximately 16,500 aspirin or ibuprofen or NSAID-related deaths in the United States per year, leading me to believe that marijuana is actually safer than many current over-the-counter drugs. Moving on to current scientific trials, in one study testing for the toxic dose of marijuana in dogs, the minimum lethal oral dose was greater than 3 grams per kilogram, and this dose is 1,000 times more than the dosage that would be prescribed for therapeutic uses. According to Dr. Grinspoon from the Harvard Medical School, on the basis of extrapolation from animal data, it is estimated to have an unheard of therapeutic ratio, which is the lethal dose divided by the effective dose, and it would be nearly 20,000 to 40,000. And just to put that in perspective, alcohol has a therapeutic ratio of 4 to 10. I'm now going to move on to the second criteria category of a Schedule I substance, which is the drug or other substance has no currently accepted medical use and treatment in the United States. Research suggests that THC and or other cannabinoids may have potential in treatment of pain, nausea, obesity, wasting disease, addiction, autoimmune disorders, and other conditions. Under the definition of marijuana previously mentioned, the cannabinoids found in marijuana would be considered part of marijuana. Currently in the United States, some cannabinoids have been approved for the following medical conditions: controlled chemotherapy-related nausea and vomiting, appetite stimulation in patients with HIV who have anorexia-cachexia syndrome, glaucoma, and multiple sclerosis. They have been approved in the forms of dronabinol or Marinol and Nabilon. Nabilon is a synthetic cannabinoid and is listed as a Schedule II drug. Dronabinol contains a synthetic THC, which is the exact same 21 carbon molecule found naturally in marijuana, yet this drug is classified as a Schedule III drug, and natural marijuana is still yet categorized as a Schedule I. If the United States is currently using cannabinoids and marijuana as a medication, then it clearly does not fall under the Schedule I criteria of having no currently accepted medical use in in treatment in the United States. And furthermore, cannabis has been accepted for medical use by 8 states since 1996, and the experiences of the doctors and state officials in these states establish marijuana's accepted medical use in the United States. Marijuana has also been proven effective for other medical uses by physicians in many other countries. In the United Kingdom, a study of 3 randomized placebo-controlled double-blind meta-analysis studies have shown that Sativex, an oral spray that contains 2 cannabinoids from marijuana, THC and CBD, is well tolerated and reduces spasticity in multiple sclerosis patients. The study, which compared Sativex to a placebo had a p-value of 0.0073 and 0.014 on 2 different occasions, showing that Sativex had a drastic decrease in muscular spasticity in the participants of the study. The FDA has to have double-blind controlled studies demonstrating the drug is more effective than a placebo in order to approve it as a medicine, and these studies do show that. And finally, my last 3rd criteria for a drug to be listed in a Schedule I category: the drug or other substance has a high potential for abuse or dependence. When moving to the topic of marijuana being an addictive substance, there has been much debate about how to define addiction or addicting. Studies have shown that marijuana can lead to psychological dependence. As far as physical dependence goes, studies vary. More recently, studies have shown that marijuana can cause some mild physical withdrawal symptoms, such as sleeping difficulties and irritability. This is not uncommon for many legal prescription drugs in the United States, however. In the most recent study published by the National Institute of Health on drug and alcohol dependence, they found that the cumulative probability of transition from use to dependence after a decade after use onset was only 5.9% of cannabis users. The same probability was almost doubled at 11% for alcohol users and nearly tripled at 15.6% for nicotine users. As much research has shown, marijuana does not fit into the criteria required for it to be considered a Schedule I drug. Our American Medical Association urges that marijuana's status as a federal Schedule I controlled substance be re-reviewed. It also urges the National Institute of Health to facilitate grant applications and conduct well-designed clinical research into the medical utility of marijuana. If our FDA has to accept current scientific knowledge when classifying a drug, then their current classification of marijuana as a Schedule I drug is outdated. In a country that bases our medical ethics on terms of autonomy, informed consent, and non-maleficence, then it is unethical to leave out a treatment option to patients that may be more safe than the currently prescribed treatment.
Okay, I'm going to argue that marijuana does belong in the Schedule I classification. The Controlled Substances Act of 1970 placed all substances into one of 5 schedules. These schedules, like Liz said, are based on medicinal value, harmfulness, and potential for abuse or addiction. Schedule I substances are classified as having no current accepted medical use, a high potential for abuse, and severe psychological or physical dependence, including distorted perceptions, impaired coordination, difficulty with thinking and problem solving, and disrupted memory and learning. This schedule, Schedule I, is the category that marijuana was placed in when the Controlled Substance Act was passed. Although some may think that marijuana doesn't belong in that schedule, it was placed into this category by officials for many reasons that have been extensively researched. Medical uses for marijuana have been researched recently. However, more research is needed to support the benefits versus the risk of using a Schedule I drug for medical purposes. During this segment, the use of medical marijuana will not be extensively argued. Instead, it is meant to show the adverse effects that marijuana has on users and to prove that it still belongs in the Schedule I drug classification. First addressed will be marijuana's high potential for abuse and addiction. According to the National Institute for Drug Abuse, marijuana is the most common illicit drug used in the United States. There has been a sharp increase in use since 2007, which also corresponds with the general public's decreased perception of the harmfulness of this drug. According to an annual survey conducted by the National Institute for Drug Abuse, more teenagers are smoking marijuana than they are cigarettes. Nearly 7% of high school seniors reported smoking marijuana daily or almost daily. Unfortunately, the common belief that marijuana is not addictive is a false one. Marijuana is addictive, meaning that the consumer using marijuana will use it to such a degree that it interferes with work, school, family, or recreational activities. According to the National Survey on Drug Use and Health, in 2010, of the 7.1 million Americans addicted to or abusing illicit drugs, 4.5 million were addicted to or abusing marijuana. 9% of people who use marijuana become addicted. Withdrawal symptoms have been reported among those who have tried to quit smoking marijuana as well. These symptoms include irritability, sleeplessness, decreased appetite, anxiety, and drug cravings. Also, of the people entering drug rehabilitation centers in 2009, 18% reported marijuana as their primary drug of choice. Of those 18%, 72% were 15 to 17-year-olds. Clearly, marijuana is an addictive substance, whether or not it has health benefits. Next discussed will be the physiological and psychological effects of using marijuana. When THC, the chemical component of marijuana, is ingested, it will enter the bloodstream and make its way up to the brain and other organs of the body. There, THC will bind to the cannabinoid receptors in the brain. These receptors are naturally occurring receptors that affect the brain's development and function. So what happens to the body when THC binds? Since the highest concentration of cannabinoid receptors in the brain are found in the areas affecting pleasure, memory, thinking, concentration, sensory and time perception, and coordinated movements, these are the things affected most physiologically. THC enhances the effects of these receptors, making the user experience distorted movements, trouble problem-solving and thinking, as well as impairments in memory and learning. Unfortunately, it has been found that even after the short-term memory loss associated with marijuana use wears off, long-term memory impairment and difficulty learning remains in chronic users of marijuana. Besides these more commonly known effects of marijuana, this drug can also have a major impact on the cardiopulmonary system. When a user ingests THC, the user's heart rate will increase by 20 to 100%, and this can last up to 3 hours. The increase at heart rate puts users at an increased risk for heart attack. According to the National Institute of Health, marijuana users' risk for having a heart attack becomes 4.8 times higher during the first hour of the drug's effect on our bodies. It can also cause palpitations and arrhythmias of the heart. Since it is commonly smoked, users of marijuana begin to experience the same side effects of chronic cigarette smokers: lung irritation, production of phlegm, and persistent cough. Finally, there have been studies that show an association with chronic marijuana use and mental illness. It has been seen to exacerbate episodes and symptoms of schizophrenia, worsening these patients' course of illness. Furthermore, marijuana use is associated with depression, anxiety, suicidal thoughts among adolescents, and personality disturbances. More research is needed to solidify these associations, though. Therefore, marijuana does have severe physiological and psychological impacts on users who choose to ingest this drug. Since Schedule I drugs are classified as having no medical use, a high potential for abuse and addiction, and adverse physiological and psychological effects on users, and since marijuana has all of these properties, marijuana does belong in this drug classification. The uses of medical marijuana are still being researched. However, much more research needs to be conducted before any changes in drug classifications are made. Not only does marijuana fit into the Schedule I drug classification requirements, according to federal law, marijuana is illegal for recreational and medical purposes, and that solidifies its classification as a Schedule I drug for the time being.